Hi, I'm Dr. Dennis Ngo, overall chairperson of the 2023 Philippine Digestive Health Week. The Philippine Society of Gastroenterology, together with the Philippine Society of Digestive Endoscopy and the Hepatology Society of the Philippines, will be holding the joint annual convention on March 8 to 11, 2023 at Conrad, Manila. After 2 years of having this annual meeting on the virtual platforms and hybrid way, we are having JAC 2023 live. The postgraduate course on the first day will cover lectures discussing common gastrointestinal and liver disorders targeted for the clinicians, family physicians, and internists. The following 3 days will be the joint annual convention proper with the theme, Empowering Filipinos in the Care of Digestive Health. The convention will provide us updates on the evolving epidemiology of certain gastrointestinal diseases, reveal new diagnostic and therapeutic endoscopic approaches and techniques, as well as current trends in multidisciplinary management options relevant to clinical practice. It will likewise give us a comprehensive coverage of the latest local research and clinical information across the fields of gastroenterology, endoscopy, and liver diseases. I think one of the really great aspects of attending the meeting is the ability to connect and reconnect with colleagues and friends from all over the Philippines, build professional collaboration, make personal friendships that you'll treasure throughout the course of your career. So I'm looking forward to the 2023 Joint Annual Convention, which will be held at the Conrad, Manila from March 8 to 11. Conrad, Manila is a great place for a meeting, and it offers the amazing views of our beautiful Manila Bay sunset. I encourage everyone to attend the 2023 Joint Annual Convention of the PSG, PSDE, HSP at Conrad, Manila. Please save the date. And of course, if you want additional information regarding the meeting, you can go to our website.
Cancers of the digestive tract, which include the colon, gallbladder, and stomach, are responsible for 117 deaths yearly around the globe. And among the leading causes of death in the Philippines are related to the digestive tract, which includes, among others, liver cancer, colorectal cancer, diarrhea, peptic ulcer disease, and stomach cancer. Once again, we bring you a range of live-streamed events via our Facebook pages in celebration of the Philippine Digestive Health Week 2023. Happening on March 5 to 11, a full week dedicated to promoting awareness to the public and all healthcare workers to take a proactive role in caring for their digestive health. Look after your gut and join us as we address various diseases and conditions relating to digestive health in the Philippine Digestive Health Week 2023.
Hi, I am a gastroenterologist and a member of the Philippine Society of Digestive Endoscopy. Some of the medical conditions involving the distal small intestine, called terminal ileum, and the large intestine are diagnosed with colonoscopy. A patient is advised to undergo this procedure when there are complaints like pain or discomfort in your belly, altered bowel habits, either constipation or diarrhea, mucus or blood in your stools, and unintentional weight loss. A person without any symptoms but who is 50 years old and above or has a family member diagnosed with colon cancer is also advised to undergo colonoscopy. Colonoscopy is a non-surgical procedure performed by a gastroenterologist to evaluate the lower GI tract, which includes the large intestine and the distal part of the small intestine. It uses a flexible endoscope with a built-in camera at its tip, connected to an image processor to examine the lumen of the intestine in real time. To aid in diagnosis, a biopsy or tissue sampling can be obtained to check the presence of infection or malignancy. Remove a colonic polyp by a snare to stop it from bleeding or before its malignant transformation. Complex procedures can also be performed, like bypassing an obstruction for advanced colon cancer using a self-expandable metal stent. This procedure can be performed safely under intravenous sedation with very minimal risk for complication. Do you experience these complaints lately? Find out if you need to undergo colonoscopy. The Philippine Society of Digestive Endoscopy can help you find the nearest endoscopy center in your area. Visit psde.org.ph.
Hi, I am a gastroenterologist and a member of the Philippine Society of Digestive Endoscopy. Some of the medical conditions involving the esophagus, stomach, and first part of the small intestine, the duodenum, are diagnosed with gastroscopy. A patient is advised to undergo gastroscopy when there are complaints like pain or discomfort in the upper part of your belly, worsening or recurrent heartburn, bitter or acidic taste in your throat, bad breath despite good oral hygiene, vomiting blood or passing out black stools, with difficulty or pain in swallowing. Gastroscopy is a non-surgical procedure performed by a gastroenterologist. Your gastroenterologist uses a flexible endoscope with a built-in camera at his tip to evaluate the upper GI tract, which includes the esophagus, stomach, and duodenum. This camera is connected to an image processor and monitor where the images taken can be viewed in real time. To aid in diagnosis, a biopsy or tissue sampling can be obtained to check the presence of infection like Helicobacter pylori or malignancy. Moreover, therapy can be done with this procedure. It can stop an ulcer bleed by deployment of clips or ligation of esophageal varices, and can even perform complex tasks like bypassing an obstruction from advanced esophageal cancer using a self-expandable metal stent. Gastroscopy can be performed safely under local or intravenous sedation with very minimal risk for complication. Do you experience these complaints lately? Find out if you need to undergo gastroscopy. The Philippine Society of Digestive Endoscopy can help you find the nearest endoscopy center in your area. Visit psde.org.ph.
Good afternoon, ladies and gentlemen. In celebration of the Philippine Digestive Health Week 2023, we bring you the Primary Care Series. Before we begin with the program, we would like to invite everyone to join us in prayer, followed by the Philippine National Anthem. Heavenly Father, we thank you for your enduring, sustaining, and faithful love. Today, we come to you and ask for your godly wisdom. Help us to hear your voice and fill us with courage and humility to follow your ways in all that we do. Condition our hearts and minds to be compassionate, to heal and to give comfort to our patients, and to take pride in our gifts and use them humbly, all for your glory. As we come together to share our knowledge and expertise, we pray that in thoughts, words, and actions, we become the community you desire. Help us reflect the beautiful nature of your word to the world, life-giving and transforming, a sign of peace and hope. All these we ask in your holy name. Amen.
Tayo po'y tumayo para sa pambansang awit ng Pilipinas.
Once again, welcome to the Primary Care Series Day 1. To officially open the program is the President of the Philippine Society of Gastroenterology. Let us all welcome Dr. Alan Policarpio.
The Primary Care Series is one of the highlights of this year's Philippine Digestive Health Week. The lecture series will be from March 7 to March 10, 2023, from 3 o'clock to 4 o'clock in the afternoon via Zoom. The topics that were prepared are tailored fit for the primary care practitioners and family physicians. It covers many gastrointestinal, hepatic, and pancreaticobiliary diseases such as dyspepsia, Helicobacter pylori infection, testing and management, gastrointestinal bleeding, colorectal cancer screening, gallstone diseases, acute pancreatitis and its complications, hepatitis B infection, and hepatocellular carcinoma. To our esteemed speakers, thank you very much for sharing your knowledge and time, and thank you for your support to the 2023 Philippine Digestive Health Week. To the organizing committee, headed by Dr. Ian Homer Kua, thank you for this wonderful primary care series that the committee has prepared. On behalf of the tripartite societies, the Philippine Society of Gastroenterology, its component societies, the Philippine Society of Digestive Endoscopy, and Hepatology Society of the Philippines, thank you very much to our dear partners, particularly the Department of Health and the various medical societies and organizations. To our colleagues in the medical profession, it is the hope and trust of our society, the Philippine Society of Gastroenterology, that after this primary care series, we take home additional knowledge on various gastrointestinal, hepatic, and pancreaticobiliary diseases which we can apply in our daily clinical practice. With this, I welcome you all. Good afternoon.
Thank you, Dr. Alan Policarpio. And now, to welcome everyone is the Medical Officer for and Program Director of the Department of Health, National Integrated Cancer Control Program, Disease and Prevention Control Bureau. Let us all welcome Dr. Clarito Cairo Jr.
Isang magandang hapon po sa inyong lahat. Welcome to Primary Care Series in observance of Philippine Digestive Health Week 2023. Pinapasalamatan po natin ang mga bumubuo ng organizing committee sa pangunguna ni Dr. Ian Homer Kua at ang mga speakers and lecturers sa iba't ibang topics po na may kinalaman sa ating digestive health. Kami po ay kaisa nyo sa pagpapalaganap ng wastong kaalaman at kamalayan para sa mga sakit na may kinalaman sa ating digestive health. Muli, kami po ay nagpapasalamat sa Philippine Society of Gastroenterology, Philippine Society of Digestive Endoscopy, at Hepatology Society of the Philippines dahil po sa kanilang pagbabahagi ng kanilang expertise upang matuto po ang ating mga kababayan sa iba't ibang sakit na may kinalaman sa ating digestive health. Mabuhay po kayo!
Thank you, Dr. Clarito Cairo Jr. We will now begin with the lectures. To introduce our speakers is our moderator. Let us all welcome Dr. Abigail Valenzuela.
Good afternoon, everyone. Thank you all for attending our Day 1 of PDHW Virtual Primary Care Series. Today, we'll be hearing from two experts regarding some of the common GI diseases in our practice. For our first speaker, Dr. Ron Michael Tan, he graduated Doctor of Medicine at University of Santo Tomas. He finished both his internal medicine and gastroenterology fellowship at Chinese General Hospital and Medical Center. He will be lecturing to us about a stepwise approach to adult patients with dyspepsia. Our second speaker is Dr. Marie Antoinette F. Absalon. She finished her Doctor of Medicine at Far Eastern University and took her internal medicine residency and gastroenterology fellowship at Veterans Memorial Medical Center. She will be lecturing about the diagnostic testing strategies and management for H. pylori infection.
Good day, everyone. I'm Dr. Ron Michael Pan, and for today, I will be discussing a stepwise approach to adult patients with dyspepsia. For definition, dyspepsia is derived from the Greek words dys and pepsi, and it literally means difficult digestion. It refers to a heterogeneous group of symptoms in the upper abdomen with an extensive differential diagnosis and a heterogeneous pathophysiology. Approximately around 20 to 25% of patients with dyspepsia have an underlying organic cause, and around 75 to 80% have functional dyspepsia with no underlying cause on diagnostic evaluation. Among the organic causes of dyspepsia, peptic ulcer remains the most common and is usually caused by H. pylori infection. Other common organic causes are gastroesophageal malignancy, biliary pain or gallbladder disease, drug-induced dyspepsia, usually secondary to NSAIDs, and some other causes such as Crohn's disease or celiac disease. Upper abdominal pain or discomfort is the most prominent symptom of patients with peptic ulcers. Although the discomfort from ulcer is usually in the epigastrium, it may occasionally radiate into your right or left upper quadrant. While classic symptoms of duodenal ulcer occur when acid is secreted in the absence of food, some patients will also develop food-provoked symptoms, and thus the utility of symptoms related to food ingestion to predict the presence of peptic ulcer disease is unreliable. Also, peptic ulcer can be associated with postprandial belching, epigastric fullness, early satiety, nausea, and occasionally vomiting. Gastroesophageal malignancy is a common cause of chronic dyspepsia. Its incidence increases with age. When present, abdominal pain may be mild in the early stage, becoming more severe and constant in disease progression. In addition, other signs and symptoms typically evolve with disease progression, such as anemia, fatigue, and unexplained weight loss. For biliary pain, the classic symptoms is that of a pain characterized by episodic, intense, dull pain located in the right upper quadrant, sometimes in the epigastrium or substernal area, and may radiate to the back. It is not exacerbated or reproduced by movement and not relieved by squatting, belching, bowel movements, or passage of flatus. The pain is usually constant and colicky, lasting for at least 30 minutes, plateauing for an hour, and the pain starts to subside, the entire attack lasting for around 6 hours. For drug-induced dyspepsia, the most common drugs that can cause it are your NSAIDs and coxto-selective inhibitors. Usually, they can cause symptoms of dyspepsia even in the absence of peptic ulcer disease or gastritis. Other drugs that can cause dyspepsia are antibiotics, quinidine, potassium tablets, some supplements like iron and vitamin B, some cardiovascular and hyperlipidemic drugs. Other rare causes of dyspepsia are your celiac disease, chronic pancreatitis, or other infiltrative diseases of the stomach such as your eosinophilic gastroenteritis and Crohn's disease. For functional dyspepsia, the diagnosis requires exclusion of other organic causes of dyspepsia. It is defined by the presence of one or more of the following: postprandial fullness, early satiety, epigastric pain, epigastric burning, and without any evidence of structural disease. Functional dyspepsia can be subdivided into two based from the latest Rome 4 Consensus Committee. Your postprandial distress syndrome, which are usually meal-related dyspeptic symptoms, and your epigastric pain syndrome, which are meal-unrelated dyspeptic symptoms. So the criteria for PDS, or postprandial distress syndrome, is that the patient may develop bothersome postprandial fullness, bothersome early satiety, without any evidence of organic, systemic, or metabolic disease. And this must be present for at least 3 days a week. Some supported criteria are your bloating, nausea, and belching. And usually, or some of the time, epigastric pain may coexist. For epigastric pain syndrome, usually the patient experiences bothersome epigastric pain, bothersome epigastric burning, without any evidence of organic, systemic, or metabolic disease, and this must be present for at least 1 day a week. For the pathophysiology, the causes of functional dyspepsia are multifactorial. Helicobacter pylori infection and acid secretion may play a role because H. pylori eradication and acid suppression improve symptoms of dyspepsia. Abnormal gastric or duodenal motility and impaired gastric myoelectrical activity are present in around 70 to 80% of patients. Other studies implicate immune activation with increased T cells, eosinophilia, and mast cells found in the bowel of patients with functional dyspepsia and even IBS. There's also an association with mental health or psychological disorders because rates of anxiety, depression are higher for patients with functional dyspepsia as compared to dyspepsia with organic cause or even in healthy individuals. There's also an overlap between functional dyspepsia and patients with gastroesophageal reflux disease as well as irritable bowel syndrome. Some studies estimate that around 50% of patients have both functional dyspepsia and GERD, and around 30 to 35% of patients have both functional dyspepsia and IBS. For the initial evaluation, history, physical examination, and laboratory tests are the first steps in evaluation of the patient with new onset dyspepsia. The goal of this initial evaluation is to identify alarm features for which GI malignancy can be seen. So some of the alarm symptoms are as follows: unintentional weight loss, dysphagia or dinophagia, unexplained iron deficiency anemia, persistent vomiting, a palpable mass or lymphadenopathy, or a family history of upper GI malignancy. The physical examination in patients with dyspepsia is usually normal, except for some epigastric tenderness. The presence of epigastric tenderness cannot accurately distinguish organic from functional dyspepsia. Abdominal tenderness and palpation should be also evaluated for Carnot sign to determine if the pain is from abdominal wall or intra-abdominal viscera. The presence of increased local tenderness during muscle tensing, which is positive for Carnot sign, indicates that the pain is arising from the abdominal wall. If negative, then the origin of the pain is not from the abdominal wall and likely from an intra-abdominal organ, as the tense abdominal wall muscles protect the viscera. Also, in physical examination, we must check for any palpable abdominal mass or palpable lymphadenopathy. Also, evidence of muscle wasting is present in an underlying malignancy. It can also have loss of subcutaneous fat or peripheral edema due to weight loss. We can also check for presence of biliary pain, such as your Murphy sign, which can indicate cholecystitis. For the laboratory evaluation, routine blood tests, blood chemistry including liver function tests, serum lipase or amylase be performed in patients with alarm features. We can also check for other blood chemistry to determine the patient's diabetes or hypercalcemia, which can also cause symptoms of dyspepsia. In the latest ACG guidelines, upper GI endoscopy is recommended for patients who are 60 years of older who have new onset dyspepsia for at least a month, because those patients have a higher risk of having GI malignancy. Then, if the patient is less than 60 but has multiple alarm symptoms, then endoscopy can also be recommended to those patients. Since we are living in the Asia Pacific region where the incidence of GI malignancy is higher, then the age threshold is lowered down to 50. So in those patients who are more than 50 years of age, endoscopy is also recommended and warranted. So here, we show the algorithm for patient presenting with primary and investigative dyspepsia. As you can see, if the patient is more than 60 years of age, we perform an endoscopy. If the results showed positive, then we treat for the specific diagnosis as indicated. If the result is negative, then we can test and treat for H. pylori. If the patient is less than 6 years of age without any alarm symptoms, the first management is to test and treat for H. pylori. If the patient has severe or multiple alarm symptoms, then we do endoscopy on a case-to-case basis. For the management, some general measures is that we should reassure and educate our patient. And we should have a positive physician-patient interaction. We ask the patient to avoid certain food, such as those food that has high fat content, those containing capsaicin, spicy food. So this food can trigger dyspeptic symptoms, so avoiding them can help limit those symptoms. Also, some lifestyle modification should be advocated, such as smoking cessation and alcohol consumption. As stated, the first line of treatment will be to test and treat for H. pylori in those patients without any alarm symptoms, because H. pylori is the most common cause of dyspepsia, and some subset of patients has improvement after H. pylori eradication. So some non-invasive tests for H. pylori are your urea breath test and your stool antigen test. So if the result is positive, then we treat for H. pylori accordingly. If the results are negative, then we can try giving empirical treatment, usually in the form of your PPI. For anti-secretory therapy, PPI provides superior symptom relief as compared to the H2 receptor antagonist. Studies show that there's no difference in efficacy between your half dose and full dose PPI. Also, double dose PPI was not superior to a single dose PPI. Usually, the response can be appreciated in around 2 weeks of treatment. The duration should be given in around 1 to 2 months. Due to the potential for rebound gastric hypersecretion, some of the patients may require long-term PPI treatment. One disadvantage of empirical PPI therapy is that there's rapid symptomatic relapse after cessation of treatment. Some other drugs are prokinetics. We have your dopamine receptor agonist, which have a stimulatory effect on upper GI motility. Under that are your metoclopramide and your domperidone. However, these cannot be given on a long-term basis because of potential side effects. For metoclopramide, you have your serious neurologic side effects, and domperidone can cause QT interval prolongation. You also have your 5-HT4 receptor agonist. So these drugs facilitate acetylcholine release in the myenteric plexus, accelerating gastric emptying. Under this, you have your cisapride. However, this was already removed from the market because of serious cardiac toxicity. Right now, we have your mosapride, another 5-HT4 receptor agonist, which does not induce arrhythmia and promotes GI motility and gastric emptying with minimal side effects. Etopride, a D2 antagonist, works peripherally, avoiding central receptor-related EPS effects, resulting in minimal elevation of prolactin hormone levels. This drug was found to be effective for global symptom improvement, postprandial fullness, and early satiety when compared to placebo. For those patients who test negative for H. pylori or remain symptomatic after eradication, or those who has inadequate response to PPI, antidepressant can be considered. For TCA, specifically remitriptane, may prove beneficial. Alternatively, buspirone can also be given, as well as amitriptyline and imipramine. So these drugs usually improve postprandial symptoms in patients with functional dyspepsia. And because there's a higher psychological correlation between functional dyspepsia and psychiatric problems such as anxiety, depression, and cognitive behavioral therapy or other psychotherapy can also be advised to our patients for those not responding to the conventional treatment. So psychological therapies with functional dyspepsia have included your cognitive behavioral therapy, hypnotherapy, and other behavioral treatment. So some recent systematic reviews showed a significant benefit of psychological therapies in reducing dyspeptic symptoms in this kind of patients. So if all of those are done, but still there's persistent symptoms, so how do we evaluate them then? So first we do endoscopy for patients with persistent dyspepsia. We do H. pylori biopsies if not previously tested. If the patient was previously treated for H. pylori, then we can do H. pylori culture and sensitivity to determine if there are any drug-resistant organisms. We can also do duodenal biopsies to check for celiac disease, and if present, and start treatment. We do abdominal imaging if symptoms are suggestive of biliary or pancreatic in origin. And in those patients with persistent nausea and vomiting, a gastric emptying test may also be recommended. So here's an algorithm for the management of patients with undiagnosed dyspepsia. As we discussed earlier, for those patients less than 60 years of age, the patient should be tested and treated for H. pylori. If positive, then we eradicate H. pylori and the treatment is a success. If negative, the first line of treatment will be to give anti-secretory drug, usually with PPI. Then we wait for at least 1 to 2 months in order to check for response. The response is minimal. Then our next step is to give your TCA. TCA was recommended in the Western countries because of the higher side effect profile of their prokinetic. However, since in our country we have prokinetics that have minimal side effects or side effect profile, then we can give prokinetic as well. If TCA or prokinetic does not elicit a good response, then we can consider psychotherapy. For patients more than 60 years of age, then we do endoscopy. If any organic cause is seen during the endoscopic findings, then we manage accordingly. If the results are normal, then we can also start treatment with your anti-secretory treatment or give treatment for PPI or H. pylori. So if the patient is positive for H. pylori, then it's a success. However, if the H. pylori is negative or no response, then we start with PPI treatment, followed by your TCA, and then your prokinetic. And if there's no response to all of these drugs, then we can consider psychotherapy. So in summary, dyspepsia is defined as one or more of the following symptoms: a postprandial fullness, early satiety, epigastric pain, or burning. 20% are due to organic causes, while some 80% are functional dyspepsia. A detailed history, physical examination, and laboratory studies are necessary to determine the underlying etiology and identify alarm features that may warrant additional evaluation. The approach to patient with dyspepsia is based on the presence or absence of alarm features, patient's age, and the prevalence of H. pylori infection in the country. For those patients who have more than 60 years of age and those less than 60 with more than one alarm features, upper GI endoscopy is recommended. If the patient is less than 60 years of age without alarm features, then the first step is to test and treat for H. pylori using the urea breath test or stool antigen test. Since we're in the Asia Pacific region, the age threshold should be 50 years of age. For patients who test negative for H. pylori, and for those with persistent symptoms after H. pylori eradication, we can give PPI. The usual recommended duration is around 4 to 8 weeks before we say that there's no response. If the patient remains symptomatic despite H. pylori eradication, and those with inadequate response to PPI, we can give your tricyclic antidepressants, your prokinetics. And those patients with persistent symptoms, psychotherapy and cognitive behavioral therapy can be offered to this kind of patients. With that, I conclude my slides, and thank you for listening.
Good day. I am Dr. Marie Antoinette Absalon, and I was tasked to talk about H. pylori infection. The objectives for my talk are the following. Helicobacter pylori is a gram-negative helical or spiral-shaped flagellated bacterium that colonizes the stomach and may lead to different gastrointestinal conditions such as chronic gastritis, gastric ulcer, duodenal ulcer, gastric adenocarcinoma, and gastric mouth lymphoma. About half of the world's population is estimated to be infected with H. pylori. However, infection rates may vary between regions, with greater prevalence in developing countries than in developed countries. The major determinant of H. pylori prevalence is socioeconomic status in childhood, which reflect levels of hygiene, sanitation, living density, and educational level. In the Philippines, the estimated prevalence was 34%. About 27 to 80% of the Filipinos presenting with dyspepsia also was noted to have H. pylori infection. This was based on study surveys published last 2018. The following risk factors have been linked to higher rates of H. pylori infection: housing density, crowded conditions in home, number of siblings, sharing of bed, and lack of hot or running water. Although there are well-described risk factors for infection, the precise mode of transmission has not been definitely established. Most infection appears to occur in early childhood, with minority of cases developing in adults. Evidences from epidemiologic and genetic studies support person-to-person transmission. Hence, a gastro-oral, fecal-oral, or possibly oral-oral transmission seems the most probable explanation for person-to-person spread. These are the evidence-based indications for H. pylori treatment. First, past or present duodenal and/or gastric ulcer with or without complications. Majority of duodenal and gastric ulcer is associated with H. pylori infection. Hence, eradication will decrease its prevalence as well as the complications associated with these lesions. Next, gastric multilymphoma, gastric mucosal atrophy, and or intestinal metaplasia, which are precancerous lesions. Following resection of gastric cancer, patients who are first-degree relative of patients with cancer. H. pylori, being a carcinogenic bacteria, is associated with the different gastric malignancies. Hence, eradication of this organism is associated with decreased risk of developing gastric cancer as well as decrease the risk of having metachronous gastric cancer in patients already diagnosed with gastric cancer. Next, functional dyspepsia, especially if the patient is living in an area with high H. pylori prevalence rate. H. pylori eradication is associated with improvement of symptoms among these patients. Next, to reduce the risk of peptic ulcer and upper GI bleeding in NSAID naive users, before starting long-term aspirin therapy for patients at high risk for ulcers and ulcer-related complications, patients receiving long-term low-dose aspirin therapy who have a history of upper GI bleeding and perforation. NSAID and aspirin in the presence of H. pylori act synergistically to promote mucosal ulceration as well as it increases the risk of developing complications such as bleeding and perforation. So, eradication is associated with decreased risk of having this lesion. Patients with gastroesophageal reflux disease will require long-term proton pump inhibitors. Long-term PPI therapy is associated with development of gastric atrophy, which in the presence of H. pylori will lead to chronic gastritis and increases the risk for developing gastric adenocarcinoma. As a strategy for gastric cancer prevention in communities with high incidence. And lastly, unexplained iron deficiency anemia and idiopathic thrombocytopenia purpura. Among these patients, if H. pylori infection has been eradicated, there was noted to have better response with treatment as proven by the study. For the diagnosis of H. pylori infection, it could be through non-invasive or invasive methods. Non-invasive or non-endoscopic methods can be urea breath test, full antigen test, or serology. These tests are recommended for patients less than 50 years old who doesn't present any alarm symptoms. Invasive methods or endoscopic methods, on the other hand, require the need to perform upper endoscopic procedure to obtain specimen that will be used for testing. These tests are generally recommended for patients more than 50 years old presenting with alarm symptoms such as GI bleeding, weight loss, persistent vomiting, among others. So first, for the endoscopic or the invasive test, rapid urease. This is the initial recommended test done by placing gastric biopsy in the urea medium in the teeth. In the presence of H. pylori infection, there will be a change in the color of the medium as a result of alkaline pH. Next is gastric histology, which detects presence of gram-negative helical bacteria in stained specimen. These tests may be affected by sampling error as a result of variable distribution and density of the organism within the stomach. Sensitivity of histologic examination can be improved by the use of special staining. H. pylori culture is not routinely done because H. pylori is a fastidious and slow-growing organism. This may require specialized media and growth environment. However, culture is recommended among patients with refractory infection for the purpose of antibiotic testing. Generally, these tests, rapid urine tests, histology, and H. pylori culture have high sensitivity and specificity in detecting H. pylori infection. For the next one, the non-endoscopic test, serologic examination is the most popular non-endoscopic or non-invasive test used in clinical practice due to its convenience and relatively low cost. In this test, IgG antibodies to a variety of H. pylori antigens is detected using ELISA technology. The sensitivity of this test is quite high. However, the specificity is variable and may be affected by the prevalence of H. pylori in the population being tested. Another disadvantage of this test is that it cannot detect active infection or be used to determine successful treatment because it may remain positive for months or longer even after successful treatment. Next, non-endoscopic test is the urea breath test, wherein the patient is asked to ingest orally administered urea tagged with carbon isotope. The generated carbon dioxide released from hydrolysis of urea in the presence of H. pylori is measured. The specificity of this test is urea breath of this test exceeds 95%, making false positive results uncommon. However, the sensitivity may be affected by the intake of anti-secretory agents such as PPI, bismuth compounds, or antibiotics. Lastly, stool antigen test. This is an immunoassay that detects H. pylori antigens present in the stool. The overall sensitivity and specificity of stool antigen test is comparable with that of urea breath test. Both urea breath test and stool antigen test can be used for determining active infection. And this test has been used for the test and treat strategy for H. pylori detection. Both of these tests can also be used to detect successful eradication after treatment. However, both may be affected by PPI, bismuth, or antibiotic intake, hence should be done not less than 1 month after last intake of antibiotic or not less than 2 weeks after intake of proton pump inhibitor. Molecular test or the polymerase chain reaction, this is a newer test that is not yet practical for routine clinical diagnosis. However, seems to be very, very promising in detection of H. pylori as well as antibiotic resistance gene. Currently, this is being utilized for research purposes, epidemiologic and transmission studies, as well as for testing of antibiotic resistance gene. So this table summarizes the different endoscopic and non-endoscopic tests for H. pylori detection, as well as the advantages and disadvantages of each test. For the treatment may vary around the world, although certain principles of treatment are generally similar. Treatment usually reflects the availability, resistance patterns to antimicrobial agents, and concerns about H. pylori-related outcomes such as gastric cancer. Since resistance to H. pylori to antibiotics has reached alarming levels worldwide, susceptibility testing prior to starting treatment is reasonable in respect with antibiotic stewardship. However, in the Philippines, the use of susceptibility-guided strategy in routine clinical practice remains to be established. Most of our regimen is based on the prevalence of antibiotic resistance in the population. First-line treatment should offer greatest likelihood of treatment success or those that is associated with more than 95% cure rate. Historically, H. pylori treatment regimen is composed of proton pump inhibitor with 2 antibiotics given for 10 to 14 days. However, recent recommendations have moved toward the standard 14-day treatment duration as shorter treatments are associated with reduced effectiveness. So this is an algorithm lifted from the Bangkok Consensus Report for H. pylori management in ASEAN countries, which was published last 2018. So based from this algorithm, if susceptibility testing is available, the patient should be started with a susceptibility-based regimen that should be given for 14 days. In the Philippines, since susceptibility testing is not available, our treatment is based from the best locally available regimen. So, for us to have an insight regarding the H. pylori antibiotic resistance pattern in ASEAN countries, I'll show you the published studies last November 15. In this study, we can show that metronidazole resistance H. pylori remains a major antibiotic resistance pattern in ASEAN countries, with Philippines having the lowest rate. Clarithromycin is an emerging resistance pattern with lower rates in the Philippines as compared with other ASEAN countries. Amoxicillin and tetracycline resistance remains rare. So based on this study survey, clarithromycin-based triple therapy consisting of clarithromycin, amoxicillin, and proton pump inhibitor is the best empiric treatment regimen as first line. So these are other first line treatment for H. pylori infection. Special mention to bismuth quadruple therapy composed of proton pump inhibitor, bismuth, tetracycline, and clarithromycin, which is primarily recommended as empiric first line by Western guidelines. Bismuth tablets are not readily available in the Philippines, hence limiting its use. This is also the best choice of empiric first-line treatment for patients with penicillin allergy because it doesn't contain any amoxicillin. So other first-line treatment, concomitant therapy, hybrid therapy, sequential therapy, and levofloxacin triple therapy. Testing after eradication. It is recommended that all patients be retested after treatment because improvement in patients' upper GI symptoms may be an unreliable guide to success or failure of eradication. Testing after eradication may not be feasible universally. Hence, priority should be given to those who remain at highest risk for harm if the infection is going, such as patients who are being treated for complicated ulcer disease related to bleeding or perforation. Biopsy-based testing, especially the rapid urine test, may be used to determine successful eradication when a repeat endoscopy is required. For example, those patients that require reassessment of gastric ulcer healing, exclusion of neoplasia, or to survey adverse histology. Otherwise, a non-invasive test such as urea breath test and H. pylori stool antigen are preferred and be done not less than 1 month after completion of eradication therapy. This is to prevent getting a false negative result. If the patient still remains positive for H. pylori infection after first-line treatment, rescue treatment regimen should be given. So here's a list of the different regimen used for rescue treatment. Levofloxacin triple therapy, bismuth quadruple therapy, rifabutin triple therapy, high-dose PPI amoxicillin dual therapy, and furazolidone quadruple therapy. So furazolidone and bismuth is not available in our country. Those regimens under the first-line treatment can also be used as rescue treatment regimen. However, a particular antibiotic used in the first line may not be included in the rescue treatment due to possible resistance that may cause a treatment failure. Regardless whether the patient is on his first line or rescue treatment, emphasis should be given with regards to the compliance and adherence to regimen, as it contributes also to treatment failure. So this algorithm is lifted from ASEAN Consensus Report showing that if the patient tested positive for H. pylori infection, first-line regimen should be started depending on antimicrobial resistance pattern of each country. If patients still tested positive after first-line treatment, second-line regimen is started wherein antibiotics not used previously or resistance is unlikely should be given. Those antibiotics such as amoxicillin, bismuth, and tetracycline have better cure rate. So if patient still tested positive after second-line treatment, patient is considered as refractory H. pylori infection. Hence, antibiotic susceptibility testing is warranted. So, for the summary of treatment, these are the different recommendations from the Western as well as the Asia-Pacific guidelines with regards to the first line, second line, and third line treatment. For the update, potassium competitive acid blockers are newer medications that can be used as a replacement for proton pump inhibitor in first line and rescue H. pylori regimen. This medication has rapid onset of action and longer acid suppression compared with PPI. The use and development of this newer medication has been largely limited to East Asian countries. Promising dual therapy with PCABs and high-dose amoxicillin for shorter treatment duration of 7 to 10 days has been supported also by East Asian guidelines. Next, probiotics. Addition of probiotics has been suggested by Western guidelines as an adjunct for H. pylori treatment. Systematic reviews and meta-analysis show that probiotics have inhibitory effects against H. pylori, causes reduction of adverse effects induced by H. pylori eradication, as well as increasing its tolerability, therefore increasing compliance. Actual recommendation, though, has still not been made, but this is a promising future medication. Studies are still needed to determine the optimal dose, time of dosing, and duration of treatment with probiotics. So, in summary, H. pylori infects more than half of the world's population and always causes chronic gastritis that may progress to severe complications such as peptic ulcer disease, gastric adenocarcinoma, and gastric mouth lymphoma. Testing for H. pylori infection can be done by endoscopic or non-endoscopic methods. Test and treat strategy is recommended for less than 50 years old dyspeptic patients without alarm symptoms. H. pylori eradication is recommended to all H. pylori infected patients. First-line treatment depends on known or anticipated pattern of antimicrobial resistance. Urea breath tests or stool antigen tests are recommended for determination of H. pylori eradication. Antibiotic susceptibility testing is recommended after H. pylori treatment failure with first-line and rescue regimen. PCABs are newer anti-secretory agents that can be used aside from PPI for H. pylori treatment. And probiotics are potential therapy for H. pylori eradication in the future. Thank you for listening.
Before we proceed, we would like to remind everyone that you may type your questions in the Q&A box in the Zoom webinar or in the comments section in Facebook Live. We will now begin with the open forum with our speakers and moderator.
Thank you very much, Dr. Tan and Dr. Absalon, for that very excellent presentation. Okay, for our first question, it's for Dr. Absalon. So, how can we test for H. pylori in a low resource setting? And some patients of ours do not have the capacity to go to the nearby city for testing. Is there a way to treat them empirically with anti-H. pylori regimen?
Good afternoon. If there's really an indication to test a patient for H. pylori, at least H. pylori serological examination for detection of IgG antibodies may be done to determine if the patient has indication for treatment. However, we should keep in mind that active infection may not be differentiated from past infection using H. pylori serological examination. We do not recommend empiric treatment without actual testing for H. pylori due to the for antibiotic stewardship.
Okay. Thank you, Dr. Absalon. For our next question for Dr. Tan, is vonoprazan comparable or superior to PPI for managing dyspepsia and GERD? And is it also recommended for treatment of H. pylori?
Vonoprazan is a newer drug. It competitively binds your potassium channel, inhibiting the hydrogen potassium ATPase pump. So the advantage of this drug is that it has higher acid suppression, and it does not require an acidic environment. Hence, theoretically, it can be used more effectively than our conventional PPI. Studies, however, are still limited to Japanese studies, but they're also using these KCAB or vonoprazan for treatment of H. pylori infection. In their studies, they recommend at least a week of vonoprazan plus your conventional antibiotics to treat H. pylori. However, it's not yet replicated in our country. Hence, I'm not really advocating a 1 week of H. pylori treatment, even with this kind of drug. So we can still use this vonoprazan, but we usually give it for 2 weeks as the previous guidelines have recommended. For dyspepsia, we can also use the low dose of this vonoprazan as well as in treatment for refractory GERD.
Okay, thank you, Dr. Tan. Follow-up PPI as first line in the treatment of dyspepsia. So the question is, how long do you usually give the treatment before you want to shift to a different class of drug?
Okay, studies the American and British studies as well as the Asia Pacific studies recommend to use low dose PPI for treatment of functional dyspepsia. And usually, before we shift to another form of drug, they recommend continuing treatment for at least 8 to 12 weeks.
Okay, 8 to 12 weeks. Okay, thank you, Ron. For Dr. Absalon, what other medication can be given for symptomatic patients who will be tested for H. pylori infection with H. pylori stool antigen or urea breath test to prevent the false negative results from using PPI?
Actually, in some symptomatic patients who warrant H. pylori testing with urea breath test or stool antigen test, drugs that do not have impact on H. pylori, such as H2 receptor antagonists like ranitidine, gastric mucosal agents like sucralfate or ribamycin, or antacids such as calcium carbonate, sodium bicarbonate, or aluminum hydroxide can be prescribed for pain relief.
Okay. Another question for Dr. Absalon. So, if you have an admitted patient who has ongoing antibiotic, for example, other treatment such as pneumonia, and turns out to have positive H. pylori, do we still give the triple therapy regimen as inpatient to your patient?
Actually, personally, I completed first the antibiotic that should be given as inpatient. Then you can give the medications for H. pylori as outpatient na lang.
Okay, thank you. For Dr. Tan again, so is there a role for antacid, alginates, or other mucosal protective agents in the treatment of functional dyspepsia?
Uh, Theoretically, since the action of this drug or the pathophysiology of dyspepsia is because of hyperacidity, we can advise to use them. However, studies have recommended that there are the effect of these antacids are that of same with the placebo. In some studies, in Japanese studies, have recommended to give ribamycin. So it's one of the mucosal protective agents which can be used for treatment of gastritis. And some studies show that it can also be useful for patients with dyspepsia.
Okay, another question, Dr. Tan. If the pain is biliary in origin, can we give pain medication? And what is the recommended drug for this?
If the pain is biliary, so we usually give this patient antispasmodic. So your hyoscine is your first line of drug. If the patient will remain symptomatic, then you can give your non-steroidal anti-inflammatory drugs. However, we should take note that persistent biliary colic, meaning progression of the disease, so your patient might be having cholecystitis already, then maybe warrant or antibiotic and subsequent surgical intervention may be warranted.
Okay, thank you, Dr. Tan. So this is both for Dr. Tan and Dr. Absalon. A question from our attendee. He's a surgeon. How to use probiotics in dyspepsia or H. pylori infection? Who wants to answer first?
Okay. Okay. For probiotics, so since one of the pathophysiology of this pepsia will be your dysbiosis, and also the link with irritable bowel is high, then probiotic can be one of the recommended additional treatment. For probiotic, some studies, this is for IBS, they usually recommend giving probiotics plus prebiotics twice daily for the first 2 months. And afterwards, they can be maintained on a once daily dosing of probiotic. There are different probiotics in the market. So we usually recommend those probiotics who have multiple strains of good bacteria and has a high CFA unit.
Okay, thank you. For Dr. Absalon, is the recommended treatment for the pediatric H. pylori the same as with the adult?
Um, Actually, I haven't encountered any pediatric patient diagnosed with H. pylori infection yet. So, with regards to the treatment of H. pylori among pediatric patients, I think I am not the best doctor to answer that question,
Okay,
since most of our patients are adults.
okay, thank you for that. We can ask with our friendly pediatrician for the dosing. It depends on the weight if it's a pediatric patients. For Dr. Tan, um, they want to know what's the low dose versus the half dose versus the full dose of PPI in giving on patients with dyspepsia.
So studies show that more than 30 milligram of your PPI is considered high dose. Before we have the lansoprazole preparation, which is 30 milligram, but I think it's not available in the market anymore. So technically, our low dose PPI are those 20 milligram, and the high dose will be your 40 milligram and above.
Okay. For our next question, again for Dr. Absalon, in patients diagnosed and who completed treatment with H. pylori, is it necessary to be tested to prove eradication?
Evidence supporting routine testing for all patients successfully treated for H. pylori eradication is limited, especially in terms of cost effectiveness, especially here in the Philippines, wherein there are areas of limited resource setting. So documentation of successful eradication may be limited to those who are at most risk for further complications if H. pylori infection remains positive. So those are the patients who are diagnosed with complicated ulcers, may bleeding peptic ulcer or perforated ulcer, or those with low-grade multiple lymphoma or gastric adenocarcinoma who are proven to have better remission once H. pylori eradication has been achieved.
Okay, due to our limited time, for our last question to Dr. Tan, what dietary intervention do you usually recommend in patients with dyspepsia?
Okay. Studies show that the dietary intervention are not that effective in treating dyspepsia. Um, they may be advised to take a low caffeine, decrease in your spicy food intake, alcohol intake, or even the low FODMAP diet or fermentable oligosaccharide, disaccharide, and monosaccharides. However, it showed that the effect it's same with placebo. However, in the clinical setting, there is no harm in advising your patient to avoid those trigger, as some will benefit in avoidance of the common food trigger. So you can still advise them, and also advise them to take small meals, small frequent meals, to have an active lifestyle, and even stop smoking for those smokers.
Okay. Dr. Tan, sorry, one last question for you. Is there any evidence to support superiority of any one particular PPI over the others?
Okay. Actually, there's no superior PPI based from RCTs. So different PPI formulation have different effect profile, but all PPIs have the same effect, that is to lower down acid. However, in the clinical setting or the clinical practice, so what PPI which we usually recommend. So first we check for other comorbidities of the patient. Is the patient taking other drugs, which might affect your CYP 219? So if yes, then you can use your PPI that does not inhibit those kind of enzymes, which are your pantoprazole, esomeprazole, and even rapeprazole. Um, because some formulation are fast dissolving drugs, so the other has a normal onset of action. For example, esomeprazole has a formulation that's fast dissolving, while some esomeprazole have the normal onset of action. So it really depends on the availability, and of course the cost for our patients.
Okay. So, thank you again, Dr. Tan and Dr. Absalon, for answering those questions and for the very informative lectures.
Thank you.
Thank you.
Okay, for the awarding of our certificate, um, first, this certificate is presented to Dr. Ron Michael M. Tan for imparting his expertise and insight on the topic, a stepwise approach to adult patients with dyspepsia during the Philippine Digestive Health Week 2023 Primary Care Series Day 1, given on the 7th day of March 2023, signed by Dr. Ian Homer Kua, Overall Chair, Dr. Marian Lini C. Hanairo, Chair of the Scientific Committee, Dr. Alan A. Policarpio, President, PSG, Dr. Carl C. U. Kim Teng, President of the Philippine Society of Digestive Endoscopy, and Dr. Angela D. Salvania, President of Hepatology Society of the Philippines. Thank you, Dr. Tan. And for our next certificate, awarded to, same certificate is awarded to Dr. Marie Antoinette Absalon for her lecture on the diagnostic testing strategies and management for H. pylori infection. Thank you, Dr. Absalon. So, and Dr. Tan again. So this concludes our day 1, and thank you again for attending. See you all tomorrow for the second day of our primary care series lecture.